Hello, my name is Hyung-Jeong. I'm a PhD candidate from the Department of Artificial Intelligence Convergence at Cheonam National University. Now, I'll present my work on the power of multimodality variables in predicting Parkinson's disease progression. Parkinson's disease is the second most common neurodegenerative disease after Alzheimer's. It affects more than 1% of the worldwide population aged over 65. The symptoms can vary from person to person and are often mild in the early stages, making them easy to overlook. Motor symptoms usually start on one side of the body and worsen on that side, even as both sides become affected. These symptoms include tremors, slowness of movement, muscle stiffness, difficulty with posture and balance, and loss of automatic movements. Non-motor symptoms, such as loss of taste, cognitive issues, and sleep problems, are also common in Parkinson's. Traditional clinical diagnosis includes genetic testing, along with a review of medical history and neurological exams. The traditional approach, however, is increasingly benefiting from the capabilities of machine learning. Machine learning uses data to learn on its own and provides insights that help diagnose and treat Parkinson's disease faster. Deep learning, a type of machine learning, is great at handling large datasets and automatically finding key patterns in raw data. Models like long short-term memory networks and recurrent neural networks are commonly used for analyzing time series data, making them ideal for predicting PD progression. The Hone and Yaw stages, introduced in 1967, track PD progression from mild to severe in 5 levels. A more recent scale, the Movement Disorder Society Unified Parkinson's Disease Rating Scale, looks at both motor and non-motor symptoms, providing a broader view. Cognitive decline, now recognized as a common PD issue, can be assessed with the Montreal Cognitive Assessment. Other tools like the Schwab and England ADL scale, REM Sleep Behavior Disorder Screening Questionnaire, and Geriatric Depression Scale help further assess PD. Modern methods also consider subtypes and advanced indicators like freezing of gait, postural stability, and fall risk. Multimodality refers to the design of multiple ways to perceive or express natural phenomena, including text, speech, images, videos, etc. In the medical field, multimodality typically includes clinical data, genetic data, and biomarkers. The International Programme on Chemical Safety, led by the World Health Organization, defined the biomarker as any substance, structure, or process that can be measured in the body or its products and influence or predict the incidence of outcome or disease. Medical biomarkers can be categorized into imaging, molecular, biochemical, and cellular and tissue biomarkers based on different detection methods and applications. In this study, molecular biomarkers and biochemical biomarkers were referred to as biomarkers. We also present the most common clinical, genetic, biomarker, and neuroimaging variables in Table 1. PD prediction using multimodal data has witnessed remarkable research attention in recent years. These reviews highlighted the potential of specific markers in forecasting PD progression, which mainly showed the correlations between multimodal markers and disease manifestations. It is crucial to note that our work aims to enhance the direct clinical relevance of these findings for PD patients, ensuring that we not only understand their current condition, but also accurately anticipate and manage future disease progression. So, we define PD progression as using past data or disease states to predict future outcomes or disease conditions. This review follows the PRISMA methodology and analyzes 59 studies on multimodality predictions for Parkinson's disease progression. It highlights key mechanisms, potential, limitations, and future research directions to guide further exploration in the field. This review excluded studies focused only on disease classification, diagnosis, or treatment. It also omitted studies that did not reflect disease progression or those that only showed associations without predictive modeling. Additionally, publications prior to 2016 were not included. Finally, we obtained 59 full-text papers. Figure 4 demonstrates the research trends in the field based on the historical usage of modalities over the years. Next, I will discuss how different modality combinations affect Parkinson's disease progression. Figure 5 illustrates the distribution of papers using different modalities. We found that all included papers used clinical data. This situation can be attributed to the distinctive role played by clinical data, the ready availability of clinical data, and its capacity to enhance predictive accuracy often lead researchers to prioritize the integration of clinical data with other modalities. The first part is clinical and genetic variables. One paper discussed the role of single nucleotide polymorphisms in influencing PD progression and treatment response. A 2019 study found a weak correlation between age of diagnosis and motor complications. Genetic factors, including GBA mutations and ApoE4, contributed to motor and cognitive progression, but integrating genetic and clinical data required advanced algorithms, which showed limited improvements in predictive accuracy. Studies on impulse control disorders found that adding genetic data slightly improved prediction, but did not significantly enhance accuracy, suggesting the need for larger, standardized datasets for better prediction tools. Non-coding RNAs have potential as biomarkers for PD, aiding early detection and progression monitoring. Cytokine levels, when combined with clinical or RNA-seq data, can help predict motor symptom progression, though individual variations exist. Models using RNA-seq data, such as one developed by Ahmed et al., improved prediction accuracy, but required consideration of noise in MDS-UPDRS scores. Biomarkers like NFL can predict non-motor symptom progression and correlate with cognitive decline, while plasma glial fibrillary acidic protein can predict postural instability. Additionally, predictors for DBS surgery eligibility include age, H&Y stage, tremor scores, and CSF tau to Aβ42 ratio. Deep learning combined with neuroimaging, SPECT, PET, MRI, is increasingly used to predict motor and non-motor dysfunctions in PD, providing early insights into disease progression. Multi-modality approaches, such as integrating radiomics, EEG, and clinical data, improve prediction accuracy for motor progression, cognitive decline, and disease subtypes. MRI techniques like SMRI, fMRI, and DTI offer valuable information on brain structure, function, and disease progression. We summarize the performance of all the papers in Figure 6. Most papers used AUC to measure prediction performance. However, due to differences in research backgrounds, these results should only be used for visualization and not for direct comparison. When additional variables were introduced, some studies showed improved prediction performance, as shown in Figure 7. For the cases of 3 modalities, some studies developed predictors using clinical, biomarker, and genetic data to forecast the progression of motor and non-motor symptoms in PD. Key findings include the role of alpha-synuclein in PD pathology, the correlation between serum NFL levels and age-related axonal degeneration, and the importance of cognitive factors in predicting outcomes. Additionally, serum lipids were found to be more accurate predictors than cytokines or genetic markers, and olfaction was identified as a potential indicator for cognitive decline. Key predictive factors for cognitive decline in PD include age, RBDSQ, UPSIT scores, CSF Aβ42 levels, and caudate DAT imaging. Models combining clinical data and radiomic features are effective in predicting cognitive impairment progression and dementia risk over time. Freezing of gait and postural instability/gait difficulty are key motor symptoms in advanced PD, with factors like DAT imaging, CSF Aβ42, and brain volume changes aiding fog prediction. Studies using 4 modalities, genetics, CSF biomarkers, imaging, and clinical variables, had identified predictors for motor and cognitive progression, with DAT imaging, p-tau/alpha-synuclein ratio, and specific genetic markers serving as significant indicators. Also, Numerous scholars of papers employing 3 modalities have demonstrated in their individual papers that the integration of additional modalities can enhance predictive outcomes. The improvement was evident even when predictive performance was achieved by adding a single modality. Although previous literature has demonstrated that multimodality variables are effective in predicting PD progression, there are notable limitations. Here, we outline future development directions to address these constraints. Only a few studies used independent external datasets for validation. Researchers should adopt clear validation strategies and provide detailed evaluation methods to enhance reproducibility and credibility. Many studies focused on classifying PD patients versus healthy individuals, ignoring disease variability. Future research should track symptom fluctuations in PD patients and use multimodal datasets to predict disease progression, rather than relying on clinical variables alone. Defining disease subtypes through learning methods presents challenges. Research should focus on testing unsupervised methods and developing robust algorithms for subtype identification and validation. Variations in neuroimaging and feature extraction can introduce biases. Standardized preprocessing procedures are needed for consistent data reliability and cross-study comparison. Data preprocessing in small datasets may lose valuable information. Deep learning methods like RNNs, LSTMs, and transformers hold potential for PD prediction and should be further explored in future research. Foundation models show strong potential for integrating diverse data types for early diagnosis and personalized treatment. However, challenges in data integration, privacy, and fairness need to be addressed. Diagnostic wait times can be reduced with remote devices like smartphones and wearable sensors. Multimodality systems can improve real-time symptom monitoring, medical decision-making, and risk management. That's all. Thank you for your attention.